Good evening. I'm Dr. Sushmita Kaushik from PGI Chandigarh, and today we'll be talking about the anterior segment OCT in glaucoma. So, the anterior segment OCT is a non-invasive imaging device. We'll talk about the principles and devices first. The principle is that it's a low coherence interferometry to measure the delay and intensity of light reflected from tissue structures, much alike the ultrasound, except that it uses sound. So the light is backscattered by the interface between tissues with different refractive indices, and it returns through the reference and sample arms, recombines at the beam splitter on their way to the detector, and that's how we see it. So basically, it has moved from a time domain configuration, which was called the TD-OCT, where the light echoes were detected sequentially, and there was a scan speed of about 200 to 2000 A scans per second. A spectral domain OCT, on the other hand, all spectral components were captured simultaneously, and the higher scan rate was achievable, which was up to 100,000 A scans per second. So why do we need it? We can easily assess the angle clinically, and you know that. There's the trabecular meshwork, there's the Schwab's line, scleral spur, ciliary body band. So when we can see this on gonioscopy, why do we need to do an anterior segment OCT in the first place? The problems with the gonioscopy are it's a contact procedure, it takes time, but frankly, is it just laziness? Is it easier to just use a gizmo? We'll come back to the problems of the AS-OCT sometime later during this talk. So here are the types of the anterior segment OCT available, and I've just put this into one table to make it understandable. One was a time domain, one is spectral domain, and one is a swept source OCT. So the names that we are most familiar with are the Zeiss Visante for the time domain, the Spectralis for the spectral domain, and the Cassia for the swept source anterior segment OCT. The wavelengths differ. The spectral domain has a least, and the time domain and swept source are similar at 1310 nanometers. The axial resolution is very good time domain as well as spectral domain and swept source, but the spectral domain has the least, which means you can pick up minute parts of tissue structure better with a spectral domain OCT. The imaging depth range is similar in the time domain and swept source, but it's again very, very small in the spectral domain, which is why for glaucoma it gets to be a little more cumbersome and it's more suited for the cornea. The line scan rate, as you can see, that is the main difference between the two. As to the scan rate is so much higher, which makes it more resolution wise as well as time wise a better machine. So 2 kilohertz versus 20 to 40 and 30 kilohertz in the others. So let's look at what we had. This is the Visante time domain OCT. It's not available anymore. It was the first OCT modified for anterior segment use with a wavelength, as we've said, of 1310 nanometers. Fairly deep penetration. You can see about 6 millimeters, which means the entire anterior chamber could be easily imaged, and it was much deeper than that obtained with a spectral domain OCT. You could get a cross-sectional view of the entire anterior segment, about 16 millimeter scan. So that was really, really useful for the angles. And the axial and transverse resolution was about 18 and 60 microns respectively. So this is a typical example of an angle image on a time domain OCT. The next generation was a Fourier or spectral domain OCT, and as you can see, the depth of penetration was very, very lower than the time domain, but the resolution was phenomenal. So you can almost see the layers of the cornea. You can see the epithelium, the Bowman's, the stroma, the endothelium. So wonderful resolution at the cost of penetration. And if you went and tried to image the angle, of course, the resolution was fantastic there as well. The axial resolution is about 5 microns here. Now, of course, we're all talking about the Cassia swept source OCT. It's made our life so much simpler. It's by Tomy so far, 1310 high resolution images of the anterior segment structures. The light source is a fast tunable laser, which is called swept source. It emits a narrow band of light with variable wavelength at a very high rate, and you can see 360 degrees of the angle or the image of the anterior chamber angle at the same time. So it combines the depth of penetration and the resolution of both the time domain and the spectral domain. So since we have a combination of the advantages of both, the CLASSIA is really our go-to machine today. So let's look at what quantitative angle measurements could be done. Now, there is a standard terminology which is used to understand the angle measurements better, and these work for the UBM also. So you would have AOD, angle opening distance, at 250 microns from the scleral spur, at 500 microns from the scleral spur. You would have anterior chamber analysis, you would have anterior chamber depth, you would have anterior chamber volume, and so on and so forth. There are a whole lot of things which you can look up. But the thing that really helps us is the lens vault, which you can't see on the UBM. The lens vault is the perpendicular distance between the anterior pole of the lens and the horizontal line joining the two scleral spurs on horizontal AS-OCT scans. So this is the lens vault, and this is the one measurement which has really helped us, especially in primary angle closure, where you want to see that even with a little bit of a cataract, if the lens has swelled, will taking this lens out help in the glaucoma bit. So this is one measurement which is more important in my mind to all the others in assessing intervention that you would do in a patient with primary angle closure glaucoma and a cataract. So what are these estimations pertaining to glaucoma? The quantifiable measures are the angle parameters, the anterior chamber, iris, lens, and corneal parameters, of course. But the problem is that a prior identification of a landmark is necessary. There's no way the machine is going to know which is the anterior chamber angle, which is the cornea, what is the iris, unless you mark it out. So strictly remember, it's not operator dependent. There is a problem that the operator has to identify the scleral spur. In an image like this, it's easy. It's this little protrusion here and the end of a line between the ciliary body and the sclera, so to say. So once you've marked this out, only then the machine can give you all those many parameters. It's important to diagnose and understand the mechanism of angle closure, because any contact between the iris and angle wall anterior to the scleral spur will be identified as angle closure. And you need to assess response to treatment by demonstrating the widening of the angles after, say, laser iridotomy or even after a phacoemulsification. So these are the little nuggets where we use these quantitative measurements in our daily, day-to-day clinical practice of glaucoma. This is a very novel concept, and it's nice to go back to this paper if you can, because they have really defined anterior segment OCT angle landmarks of the trabecular meshwork complex. So what it is a presence or absence of angle landmarks, trabecular meshwork, Schlemm's canal, and bell. And we'll just know what the bell means using AS-OCT. So out of the 303 angles of 153 I studied, the outer border of bell was observed in 288. 95% of angles you could identify an outer border of the bell. Now what does this bell mean? So this is what this is. This is a band of extracanalicular limbal lamina. So if you see this bell, this band of extracanalicular limbal lamina, this white thing beyond that, all the structures in front of this is really the trabecular meshwork. So this is something which is really helpful in identifying trabecular meshwork, and then you can see whether the iris is come in contact with this structure or not, which you always identified as trabecular meshwork. So bell is something new that has come in. This is the drawing of the bell, so to say. This is the trabecular meshwork, and between them, as you know, the trabecular meshwork makes the Schlemm's canal by joining the roof of the scleral sulcus. So the dotted line is bell, the solid red line is trabecular meshwork, and the asterisk is the Schlemm's canal. And this correlates very well to histology. This is a histological section. So if you can identify the bell, the trabecular meshwork, and between them lies the Schlemm's canal. So this, to my mind, is one really important identification which is possible with the AS-OCT now. So what else does it do? It gives us non-pupillary block mechanisms of angle closure, like this, for instance. If you have a subluxated lens, you can see that there's anterior chamber asymmetry. In one side, it's completely occluded. In one side, it's a little bit, it's narrow, but there is a chink of AC there. And if you look at this, it's actually showing you a subluxated cataractus lens, which is why it's so dense. Then, if there are mechanisms other than pupil block, look at this large lens wall. This is what we talked about, a line joining the scleral spur and a perpendicular drawn to this to the anterior pole of the lens. And this, to my mind, will be a large lens wall, at least 1,000 microns. And this is an indication that removing this large lens will probably be beneficial for angle closure disease in this patient. Ciliocroidal effusion. Another thing, if you have a bilateral sudden myope and you have angle closure in a patient who is perfectly fine, look for fluid in the ciliary space. Of course, the penetration is not as good as a UBM, and you might be able to see it on the UBM better, but there are times when you can go back on the cassia and you will pick up the ciliocroidal effusion. The importance of that is an angle closure due to ciliocroidal effusion requires atropine and steroids as opposed to pilocarpine and a laser iridotomy for primary angle closure. And if you reverse these, then it's a doomsday for the patient as well as for us. And then if there's localized angle closure due to iris cyst, now this is an iris cyst which is not so visible on the AS-OCT, but it would be much more prominent on the UBM simply because light doesn't penetrate tissue so well. The next thing you can do, of course, as a glaucoma surgeon is to visualize the bleb. So you can see this is again a cassia. This is a line passing through the bleb. This is a bleb. And you can see here, there's hardly any fluid in the subscleral space. So on the AS-OCT, you can make out a bleb wall thickness. You can make out the cavity, the flap, and the ostium. And multiple hypoechogenic areas indicate microcysts is indicative of a good bleb. So here is the osteotomy, and then as you go here, this is a flap, and there are a little bit of microspaces, but then probably this would do well with a massage or maybe a needling or something. Now, AS-OCT imaging of a glaucoma drainage device complements clinical examination. So you can see the patency and position of the tube and the presence and extent of tube corneal touch and tube iris touch. You can see this tube, it is really indenting the cornea. So you know that this is really touching the peripheral cornea, and it is also indenting the iris in the periphery. So this probably is a shorter tube in a very shallow AC, and you can actually visualize it and monitor it over time. So glaucoma drainage implant positions, sometimes you don't see them so well unless you use a gonioscope, and that's an important indication for us to do an AS-OCT. So what are the advantages of the UBM? Of course, it's non-contact. Situations that preclude contact with the eye, it's very useful, especially immediate post-op or in bad corneal conditions. An anterior segment trauma, you can use it to assess the extent of the corneal or scleral injury if you're not sure if it's lamellar or full thickness. And of course, if you have an intraocular foreign body or a corneal foreign body which is tiny or small, maybe the AS-OCT could help bring that up. So we'll go through some clinical applications with this background and see how we've used it in some patients in our clinic. Now, can you as a glaucoma person do an almost clear lens extraction in primary angle closure disease? So this patient with primary angle closure, you can see that the left eye is so much more is advanced glaucoma. You can see the fields on the 10-2 is nearly wiped out in the superior quadrant, and there's hardly any inferior rim. So now when we did an AS-OCT, if you can see, the lens vault is pretty much high. So it's a high lens vault. So this was PACG with a high IOP after LPI, high lens vault, and lens extraction would be beneficial for him. Once it's PACG, but remember, phaco alone cannot be an option. If there's a high lens vault, a trab alone would be very problematic, because if you're going to increase outflow, all that lens iris diaphragm is going to move forward, you're going to be in trouble. So if the intraocular pressure is controlled medically, one would do a phaco followed by a trab, and if the IOP is uncontrolled, you would do a phaco trab. But an AS-OCT would give you an idea as to whether the phaco surgery would really be beneficial or not. Now, this would be a typical patient for early lens extraction. Look at his phonesis. This is drug allergy or preservative allergy. He's sick of his anti-glaucoma medications, which he's probably had for years and years and years. Advanced glaucomatous optic neuropathy, medically controlled but intolerant to medication, and again a high lens vault. So you can see the lens vault here is 897 microns. So that's pretty high. So even though he has a minimal cataract, we chose lens extraction. The IOP was better. Look at the drug requirement. Since the drug requirement has gone down, his ocular surface has come better. He's a happier patient. And now we've planned the same for the other eye. And you can see the angles, which were so crowded, have now actually opened up a bit. And you can see the trabecular meshwork in front of Bell is now facing the anterior chamber. So we hope that with all this, he can have reduced dependence on medication and a more stable glaucoma. When a trap bleb fails, we've talked about how we can look inside a bleb. So here it is, a patient with a failed trap, absolutely scarred bleb. And this is what it looks like on the OCT when you're in a dilemma of whether I should needle it or whether this requires a full bleb revision. Now, so you can see this is the PI, this is the bleb. Now, for a trabeculectomy like this, with the scleral flap completely occluded, there's no point in doing a subtenons needling because this is not going to work. This is not going to put a communication between the anterior chamber and the bleb. So we did something called an ab interno revision, and what we do in that is we just go in with this large Grover-Feldman spatula, and you can see the end of it is coming out in the subconjunctival space through the scleral flap. So this is really through the scleral flap, and you can see post-operatively compared to this how much more fluid is in, and it's restored flow. And the best part is that it restores posterior flow. So these blebs rather do quite well. But AS-OCT helps us decide what to do. The other thing, it helps in optimal planning in complex situations. So, for instance, this patient, you can see an OPK and very, very advanced glaucoma, that's a medillated nerve fiber. The IP is actually 62 millimeters. This graft is going to fail if we don't act fast. He's intolerant to Diamox. So he's just on glycerol and topical AGMs, and IFPs are still 50. So you need to do something even though an OPK has been done. But where do you put in the GDD? You have no idea. This is a phakic patient, and there's no peripheral anterior chamber at all. And so we did the AS-OCT, and sure enough, you can see that there is actually no peripheral anterior chamber. So where are you going to put in that lens? And this is phakic. So if you're going to put it in here, if you're going to put a tube in here, sorry, not the lens, tube in here, you have almost 100% chance of having a tube lens cut and then developing into a cataract again. So there's no option of the sulca. So we did the phaco first. We made the space and then we went ahead and did the GDD. And you can see that with the space there, there's so much there where you could do the GDD. So this really helps us plan, and it helps us in pragmatically choosing what to do and how to do the best for the patient needs. So the next question, can we use it in children? We can. This is actually called a flying baby technique. It's been done by our pediatric ophthalmology colleagues. This is a photo courtesy Dr. Ashok, my senior resident, who has done a couple of AS-OCTs, or quite a few of them, on our babies to see what the angle dysgenesis really looks like. And you need a speculum, and if the baby is quiet and well fed, it's all right as long as it's in the mother's lap and the mother is holding the baby. And we actually call it a flying baby. So look at this. This little kid has come with a bilateral congenital corneal haze and referred as primary congenital glaucoma. She's 3 weeks old. There's no history of watering or discharge. Full-time normal delivery. Cried immediately after. Immunization is up to date. Antenatal, natal, postnatal, everything is uneventful, and torch profile is normal. So on examination, she has a diffuse corneal haze. There's no limbal stretching. The IOP is 12 and 13 on eye care, but of course she has corneal edema. But even through the hazy media, we could see a 0.2 to 0.3 cup to disc ratio, which is a little larger for a 1-month-old girl, but then and the ultrasound was normal as well. So the differential diagnosis of this is congenital hereditary endothelial dystrophy or mucopolysaccharidosis, but unlikely to be PCG because we really didn't see any other signs except for this diffuse corneal haze. But is there any way to be sure? AS-OCT, can it tell us? So what it showed us was with that flying baby is homogeneously thickened cornea with a CCT of 1004 and 1014, which is huge. It's more than double of most adult corneas. But in the angle, the trabecular meshwork is clearly seen. So how beautiful it is. The trabecular meshwork is completely open to the aqueous. There's no high iris insertion. There's nothing. It's very unlike that this is actually a trabecular dysgenesis. The iris is nicely inserted on the ciliary body and looks as though the trabecular meshwork has also developed well. So there's no angle dysgenesis, and we concluded that it must be CHED, but again, to be sure, we got a clinical exome sequence, and those results confirmed what we thought. It was homozygous for a corneal endothelial dystrophy, autosomal recessive, and likely pathogenic. So you had a mutation in the SLC4A11 gene specific for CHED. So we reviewed the AS-OCT in children with glaucoma. We wanted to see that what do they really look like. It was just a question. And lo and behold, this was a unilateral PCT in the left eye. Look at the right eye. The iris is much further back. And yet look at the left. There's hardly any trabecular meshwork visible. And this is inserted high, almost at the level of the Schwab's line. That's a high insertion of iris. There's hardly any trabecular meshwork visible compared to the right eye, which maintain normal pressures, and you see that it's actually looks quite normal. So this is a late onset PCT. Here you see this high iris insertion and a concave iris configuration. This is what we see on gonioscopy. So there's no great shakes that the AS-OCT is telling us, but it's nice to show the patient an image and see for ourselves that this is what really high iris insertion means. And as the eye grows, because the iris is inserted high, it falls back on the lens like a little hammock. And this is the concave configuration that we see in JOAG or late onset PCT. This baby, for instance, had actually Axenfeld rigor, but like an aniridia almost, because it was so, there were just stumps of iris, it was so bad, and yet you can see how high it's inserted, and there's no trabecular meshwork visible. So what about gonioscopy? I mean, we've been talking about the AS-OCT and we've been talking about UBM as well, but angle assessment, and where does gonioscopy come in? Remember, gonioscopy is the gold standard against which all standard imaging devices are determined. So this is the mother of angle imaging or angle examination. The ease, cost, and feasibility of gonioscopy, there's no debate. This is one of my favorite pictures. I've shown it so much. This 3-year-old girl also lets me do a gonioscopy. So there's no question compared to putting in an eye cup, putting distilled water, a big probe of the UBM, and this expensive big monster of an AS-OCT, and depending on that, this little device that we have. It's indispensable if iridocorneal contact is present. Now, is it appositional or synechial? There's no way this AS-OCT is going to tell you that. And yet all you need to do is a bit of indentation gonioscopy. So this was the angle without indentation, and this is with indentation. So this is an appositional closure, which tells me that all I need to do is maybe a peripheral iridotomy, and this PSE might reverse or might be normal. But the AS-OCT shows the whole angle is closed, and I have no idea or no pointers to go towards whether or not I should just leave it at an LPI or be a little more aggressive. Similarly, so look at this angle recession and cyclodialysis cleft demonstrated well on imaging. This is a pre and post LPI iris configuration demonstrated very well. So this is pre and this is post. So how the iris has flattened. But then do I need imaging to tell me that? The gonioscopy on the side is telling me exactly the same thing that the imaging is telling me. So I don't really need it for that. And how would quantitative imaging show me these things? So I would like to see a subtle Sampaulosis line in maybe an old man with pseudo exfoliation, a painted trabecular meshwork in pigment dispersion syndrome like this, or a blood in Schlemm's canal, like Sturge-Weber syndrome. Where would AS-OCT show that? Or a broad-based PS in uveitis, or even iris processes, the typical Y-shaped process in Axenfeld Rieger syndrome. So there's a whole lot of qualitative information that your gonioscope is going to give you. So we can't go away with the fact that not having a gonioscope is an option. And AS-OCT is useful, of course, but in the clinical context to answer specific questions that you are asking the machine. Similarly, I can go on and on. Silicone oil, this is neovascular glaucoma with blood in the angle. These are the nodules of Cogan-Rees in ICE, and this is the essential iris atrophy. This is the angle closure due to NVG. So this is the same patient after an anti-VEGF, and you can see the ciliary processes underneath this, which shows that it's a pulling mechanism of angle closure. And this, of course, is Chandler's with a little bit of corneal edema there. So all these are important conditions which are all diagnosed by clinical evaluation on gonioscopy. And just to show that these are things with AS-OCT is not going to show you. So these are things to keep in mind. So, okay, the big question is whether it's useful for screening. And let's see the evidence. So this was a large study where 2,000 odd subjects were screened for narrow angles using 3 machines, the AS-OCT, the IOL master, and the peripheral anterior chamber analyzer. The sensitivity and specificity were as follows: 90 and 76, 87 and 77, and 88 and 62. So the low specificity may limit the usefulness in screening for narrow angles. So you're going to miss it. So you take a machine out into the periphery. You say we are all going to screen for angle closure disease, and you'll miss 40% of them. So what's the point? You've given them hope, and yet you haven't done justice to what you set out to do. Similarly, another study to detect PSCS, 425 eyes of 431 subjects. PSCS was first diagnosed by gonioscopy and then was put to a Van Herrick AS-OCT pentagram and again SPAC. The AS-OCT specificity was 87 and sensitivity was only 73. Again, we were missing out. None of these tests evaluated achieved the combination of specificity and sensitivity needed for a population-based screening. So, is it observer independent? Now, in one study, the scleral spur couldn't be detected in 30% of the anterior chamber angle quadrants, especially in the superior and inferior quadrants. So, if you can't detect the scleral spur, you cannot get quantitative estimations. So, there was one interesting one where there was comparison of Visante, Cirrus, and gonioscopy. Angle closure, respectively, was detected in just 18%, 16%, and 48% of quadrants, and the scleral spur in only about half. There's a slight agreement with gonioscopy and the Visante, but a good agreement in angle closure risk assessment between 3 examiners. So if there are 3 examiners doing a gonioscopy, they all agree. But if you compare it to a machine, there's not much agreement. Right, so let's see what the experts say, and this is the consensus statement of angle closure glaucoma. And quote unquote, it's indispensable to the diagnosis and management of all forms of glaucoma. Anterior segment imaging devices may augment the evaluation, but their place in clinical practice needs to be determined. To summarize, imaging the angle and anterior chamber has changed the management of childhood glaucoma, of course. More rational, more informed choices of management, but still technology used as an ally rather than master. And as for all imaging modalities, you can't use it in isolation. Thank you, and I acknowledge my senior residents who constantly put together images and help me make presentations like this. Thank you, everyone.